the coordinator of this course, for inviting me to speak a bit about this interesting topic. I will be talking about increased nuclear translucency and cell-free DNA. So in 1992, Professor Nicolaides introduced the concept of increased nuclear translucency to identify fetuses at risk of chromosomal abnormalities and fetal defects, proposing a cutoff of 3 millimeters. And the discovery of nuclear translucency was a revolution in the field of fetal medicine because it allowed to introduce the first trimester combined test for common aneuploidies. And we know that it has a detection rate of 90% if we include nuclear translucency and maternal biochemistry, and it reaches 95% if we add additional markers. But in 2007, there was a second revolution when the group of law demonstrated that fetuses with trisomy 21 can be identified by isolating cell-free DNA from maternal plasma. And in 2011, the test was introduced in the clinical practice as an alternative screening method for common aneuploidies. And since then, there have been numerous studies that have proven that cell-free DNA is currently the best screening test to assess the risk for trisomy 21, 18, and 13. And from the latest meta-analysis by Professor Gill, we know that the detection rate for trisomy 21, 18, and 13 is very high, around 99% or even higher, at a very low false positive rate for singleton pregnancies. While in twin pregnancies, the detection rate is high for trisomy 21, seems to be lower for trisomy 18 and 13, but the numbers were too low to draw definitive conclusions and give recommendations. So cell-free DNA has been introduced by all main guidelines as a screening test mainly for common aneuploidies, and it has been proposed either as a primary or as a contingent test after the combined test. So considering the striking results of cell-free DNA for the screening for the common aneuploidies, should we completely abandon the combined test and the measurements of nuclear translucency? The answer is a big no, but I'll try to explain you why. And before answering this question, we need to ask ourselves, what do we expect from a first trimester screening policy? Because if we want for common aneuploidies, there is no doubt that cell-free DNA is the best method of screening available to date. But if we want to keep measuring the nuclear translucency to screen for fetal defects and to screen for preeclampsia, we shouldn't forget about that. We need to keep offering the first trimester ultrasound. And why should we be measuring the nuclear translucency? Because we know that an increased nuclear translucency carries an increased risk of genetic abnormalities other than common aneuploidies, such as rare autosomal trisomy, submicroscopic imbalances, single gene disorders, but also structural malformation. And this risk is particularly higher if the nuclear translucency is at or above the 99th centile, which corresponds to a fixed cutoff of 3.5 millimeters, irrespective of the gestational age. And this risk increases as the nuclear translucency thickness increases. And the association is so well known that all main guidelines recommend to offer an invasive test if the nuclear translucency is at or above 3.5 millimeters. And the type of genetic test recommended is QF-PCR as a first-tier test to quickly exclude common aneuploidies, and then if negative, chromosomal microarray analysis is recommended as a second-tier test. And these recommendations are based on a series of studies which are grouped in this meta-analysis published in 2015, in which the authors show that the overall yield by CMA is around 5%, and specifically of 4% if the increased nuclear translucency is isolated, and 7% if it is associated to structural abnormalities. So what do we miss if we perform cell-free DNA in patients with an increased nuclear translucency? There have been a series of studies, and the diagnostic yield of chromosomal microarray analysis is reported to be around 3 to 6%. But we need to consider that, at least in Europe, around 80% of countries, the practice is to offer and perform an extended cell-free DNA panel, maybe even before the first trimester scan. And counseling these women when the nuclear translucency is abnormal and cell-free DNA screening is normal may be challenging. So we need to know how good is cell-free DNA at diagnosing genetic abnormalities other than common aneuploidies. And we have performed a series of meta-analyses in which we evaluated the performance of the test for rare genetic anomalies other than common aneuploidies. And we have found that the overall positive predictive value for sex chromosomal aneuploidies was around 49%, with an increasing PPV for those sex chromosomal aneuploidies that had a Y chromosome. 11%, so quite low for rare autosomal trisomies, and 38% for segmental copy number variants. So the performance of cell-free DNA for these diseases is quite low, and there are some main reasons which are responsible for that, which are mainly the low prevalence of these diseases in the general population, the phenomenon of confined placental mosaicism, which is particularly important for sex chromosomal aneuploidies and rats, and the high rate of miscarriage before the first trimester scan for complete fetal rats. So one more thing that we need to remember is also maternal age. And in these interesting studies, they evaluated the residual risk of a genetic abnormality in the setting of a nuchal translucency higher than 3.5 millimeter and normal cell-free DNA test. And the residual risk was around 50% for women younger than 35 years compared to 29% for women older than 35 years. We know that these women have a higher risk of common aneuploidies, so this concept may seem trivial, obvious, but we need to keep it in mind that we have a younger woman with an increased nuchal translucency and a low-risk cell-free DNA, because in this particular woman, the indication for an invasive test and CMA may be even more important. And what about single gene disorders? From this study, from the group of Bilardo, we know that single gene disorders are around 2%, of which 50% were razopathies, with a median nuchal translucency of 6.6 millimeter, which support the indication to look for razopathies when the nuchal translucency is at or above 5 millimeter or at or above 3.5 millimeter plus a fetal defects, such as distended jugular lymphatic sacs or eye drops. So what would happen if we perform exome sequencing in all fetuses with an increased nuchal translucency and negative CMA? So from this meta-analysis by the group of Borrell, we know that the diagnostic yield will be around 4%, so similar to the CMA in case of a negative QF-PCR. But if we look at this study, the authors found that the overall incremental yield is indeed around 5%, but it drops to 1.4% if associated defects are excluded at the second trimester scan. So this highlights the concept that in these cases, increased nuchal translucency, negative CMA, it is important to perform sequential detailed scan in order to rule out or to diagnose fetal defects that may guide us in the genetic workup. And what about the cutoff? So is the 99th centile the optimal cutoff to identify fetuses at risk, at increased risk? So there have been some studies with a bit of heterogeneity about them, because some of them consider only the nuchal translucency between 95th and 99th centile, others the subgroup with a nuchal translucency between 3 and 3.5 millimeter. And they found a diagnostic yield of around 1 to 2%, so not particularly increased compared to the general population. So the decision to perform an invasive test should be based on an accurate counseling and also on local policies. And we need to remember that to date, only the SMF guideline consider the cutoff of 3 millimeter to offer and discuss the invasive test with CMA. And with Professor Stampaglia, we have performed this study on the clinical impact of the first semester nuchal translucency between the 95th and 99th centile in all fetuses that underwent the combined test, the first semester combined test. So not only those that underwent an invasive test. And the rate of genetic anomalies was 12%. Specifically, the typical chromosomal abnormalities were 10%, atypical chromosomal abnormalities were 2%, and only 1% were pathogenic CNV. So not such an increased risk compared to the general population. But what was interesting is that all atypical chromosomal abnormalities were found in fetuses with fetal defects, and in some cases, the diagnosis of the fetal defects driven the genetic workup. So we need to consider what is the risk for this subgroup of fetuses to have a fetal defect, and we had a rate of around 13%, which is comparable to 9% reported from a recent study. So there is some evidence that fetuses with a nuchal translucency between 95th and 99th centile have an increased risk of fetal defects with or without genetic abnormalities. So I think that maybe we should discuss about an indication for a referral for detailed anomaly scan, and maybe the invasive test should be offered after a detailed scan is performed. We all know that an increased nuchal translucency increases the risk of cardiac defects. And in a study by Professor Nicolaides, they found that 36% of fetuses with a major CHD had a nuchal translucency between 95th and 99th centile, compared to 21% with a nuchal translucency at or above 99th centile. But to date, the indication for a detailed fetal echocardiography is present only for a nuchal translucency higher than the 99th centile. And there were also other studies that showed that these fetuses have an increased risk also of other structural birth defects. So we need to carefully look at the anatomy of fetuses with an increased nuchal translucency, and maybe also when the nuchal translucency is between 95th and 99th centile. And what about an increased nuchal translucency at less than 11 weeks? We know that it is becoming more frequent to do an early first trimester scan at around 10 weeks before offering the woman the cell-free DNA. So in this paper, the authors divided in two subgroups. So those with a focal edema, and that was defined as equal or above 2.2 millimeter, which is the 95th centile at 10 weeks of gestational age, or those with generalized edema. And the rate of relevant chromosomal abnormalities was 19%. Of course, those with a generalized edema had an increased risk. The rate of structural anomalies was 4%. And the overall adverse pregnancy outcome was 24%. By the way, a high proportion of these fetuses had a spontaneous resolution at 11 to 13 week scan, 80%. And in these cases, the adverse outcome of pregnancy was around 11%. But if we look at those fetuses with a persistently increased nuchal translucency at 11 to 13 weeks, the rate of adverse outcome of pregnancy was much, much higher, around 80%. So when we see these fetuses with an increased nuchal translucency at 10 weeks, we need to perform an appropriate counseling, and we need to bring them back at 11 to 13 weeks to check again and to decide which is the best screening method, and maybe if they need an invasive test. So to conclude, we can say that cell-free DNA is the optimal screening test for common aneuploidies, but the positive predictive value for different genetic abnormalities is still low. The first trimester scan should not be replaced by the cell-free DNA alone. If the nuchal translucency is equal or above 3.5 millimeter, an invasive test is indicated with chromosomal microarray analysis if QF-PCR is negative. And exome sequencing may be indicated if additional abnormalities are detected or in case a nuchal translucency is equal or above 5 millimeter. For a nuchal translucency between 95th and 99th centile, the invasive test should be carefully discussed with the couple, but a detailed scan to exclude associated fetal defects should be offered. And professionals must be trained to provide adequate information to ensure that a woman is fully aware of the possibilities and limitations of the screening strategies she is choosing. And I thank you for your attention.
Ilaria,